So when I sent in my the title, I said why pharmacists should manage all warfarin in the community, and someone said it was that was fairly provocative, but I thought, well, it's quite good to sort of have conversations about these things. So this is our pharmacy in Hamilton, Pharmacy 547, and what I'm going to do initially is to show you the set of slides that we produced back in 2009. We actually did this in 2009 when we did this little wee pilot. And these were the slides that we used initially, which gave us the funding to start off the initial pilot, which was with 15 pharmacies, which was with funding from Health Workforce New Zealand and was managed by Professor John Shaw out of Auckland University. But this was the initial slides and the initial ideas which led to it all. So at the time, the government had the slogan, better, sooner, more convenient, so we just grabbed that and we said, warfarin patient care in the Waikato. And so this is what we said, pharmacy can do it, we love it, the community loves it. It was actually a huge paradigm shift in a way for pharmacy. What I always say is when I was a young man and I went into pharmacy, the reason why we went into pharmacy was that we could be involved in health, but we didn't actually have to touch people. And we didn't have to look at anything dodgy or anything like that. So this was a huge paradigm change because all of a sudden we were sitting in rooms and we were touching people and we were having one-to-one interactions. There's a famous Canadian lecturer who says that one of the problems with pharmacy is as opposed to medicine. So medicine has at the end of their name MD, and MD means make a decision. And often pharmacists are guilty of not making decisions. So a doctor will say on a ward, no, what do you think we should give for this? And a pharmacist will say, well, you could give this, or you could give that, or you could give the next thing, or there's a really good new product which you could maybe go for this. But it's just because pharmacists often work in community and dispensaries, and it's all very congenial, and we're not really used to the idea of making decisions. Whereas all of a sudden in 2009, when we were doing this, we were actually forced with the situation to actually think about what decisions we were actually going to make to do with people's warfarin. So this was just what we said, this is what the existing service was. So the patient would go to the path lab first thing in the morning, they'd go in, as you know all these things yourself, they go and they see, they have their blood taken, then in the early afternoon, 4 o'clock or so, the results are sent back to the medical practice where the nurse rings up the patient between 4 and 6 and says, this is what your INR level is and this is what your warfarin dose should be for the next period of time. For me, I always thought that the reason why patients took warfarin at 6 o'clock at night was some sort of clinical reason. It wasn't really my understanding that the reason for that was so that nurses actually had time to be able to ring the patients and say, so now the reality is that patients who come to us who are on warfarin, we just say you can take it whenever it's convenient for yourself as long as you're always taking it at the same time. So this was our service that we were able to set up. So this was us working with Roche and Paul Harper, who's the haematologist from Palmerston North, who had already set up this system called INR Online. The reason why I was really keen on doing it is that my mother, who's sadly deceased, but she had bowel cancer, and as a result of her surgery she ended up having strokes and had to go into warfarin. She lived in Tauranga. She of course had problems with her memory after a stroke. I could organise from Hamilton, I organised the pharmacists across there to organise all of the medication for her and could change her doses and all those sorts of things for warfarin. But she actually had really bad veins, and so they used to have a mobile laboratory nurse used to go around and take her blood once a week often, and she would end up being badly bruised all over and things like that. So I kept on thinking there must have been a better way. So when I first saw the Coagucheck, I thought to myself, well, this is so much better than what happens at the moment. So we started in July 2009, and the way that it works, the patient comes into the pharmacy anytime when it's convenient to them. We have a simple interview process. The pharmacist does an INR test using the Coagucheck point of care. The results come up on the machine, and then we determine what the dose is going to be for the next period of time, and then we can then produce a chart. And what we discovered, of course, is that patients actually really enjoyed that interaction, and it was that one-to-one that we're having there in real time which could make a big difference. So when I was listening there before about the interactions that like to do with food and alcohol, I remember a school teacher just beside where the pharmacy is, and her sitting there at Christmas time, and her INR was all over the show, and she said, oh, that's because I'm drinking heaps of red wine at the moment, with it being at Christmas time. Maybe I need to make some lifestyle changes. So it was it's amazing how everyone can sort of understand graphs and numbers and things like that. The very people with very little health literacy will take a big interest in actually being able to talk about it there in real time. So as you probably know then, as a result of that, of what we did there, it ended up getting rolled out. But then this is what the results were that we were able to get, that we were able to achieve. So of course we're all looking at time and therapeutic range. And what we were able to do, we actually had 24 patients who were already on warfarin. And we ended up, the reason we weren't doing this particularly scientifically, it was only purely a proof of concept. We ended up with 30 patients because over that period of time we actually ended up having 6 initiations. It's always felt, we end up with this difference of, do pharmacy only manage the difficult patients, or do they manage the easy patients? And the reality is often we have all the difficult patients being sent to us to start off with. And our great, nearly my great moment of joy, you're funny throughout your career, you get sort of little wee periods where you all of a sudden really smile and think that you may be getting somewhere, was the Monday morning when the pharmacist said to me, I had a funny thing on the weekend. I had the ambulance come down from Waikato Hospital with a patient in the back, and they came down for us to do their INR test because they couldn't get their veins in the hospital. We did it there, and 2 minutes later they were driving back up to the Waikato Hospital because they had their INR test. So at that stage you sort of think that you may be getting somewhere. So the time and therapeutic range, we were able to look back and we could see that of the patients that we had, we were able to end up with our patients being at 76% time and therapeutic range. Before that they were 55% in therapeutic range. And then you can see the ones which were below range and those which were above range. There's not any really good data out there which has gone and looked at how well the current system, with using laboratory nurses and GPs, operates. But any of the data or any of the published papers out there shows that there's no one really actually gets up to the 60% time and therapeutic range. So that showed with those patients what the difference made for those 24 patients. So those were the ones who were already above 60%. These were the patients who were below the 60%. And as you can see, we managed to move nearly everyone all up above the line for time and range. And we had a high level of compliance. So we had 92% of people coming on time. And the funny thing was, so we started this in July, and in about October, Paul Harper rang me up and said to me, what are you doing right? And I said, well, I don't know, we're doing what you told us to do. He said, because you're getting miles better results than what, because at the same time there were 7 GP practices which were also doing, using the Kogi check and doing INR, and he said to us, why are you getting so much better results than the GPs? And I sort of said, well, I don't really know, we just follow the algorithm and we don't really tutu with things very much. So that was probably sort of the basis that it maybe gave us, just for those 30 patients, a degree of credibility. At the same time, we just did a qualitative analysis. We asked patients what they felt about it, and then we just put it into Wheedle. So you can see there, what patients thought about it. They know service and helpful and good. And then again, you're always looking at what the potential risks are with patients on warfarin. So this was just showing the potentials of adverse events. And then, of course, we're working with Roche and Paul Harper, who are wanting to, of course, look and say, how do we actually get this rolled out? How do we actually get this taken on board? So they were looking at what were the potential savings? So always the savings are, what is the cost of when someone has a bleed? What is the cost of someone ends up having a stroke? And of course that's what they were then using when they were presenting this to health workforce, to try and get traction to say, well, how can this actually get, you give us the funding for this. And of course what people would always say is, well, if you get everyone coming in every day, you might actually get really good time and therapeutic range. So were you being significantly, were you having people coming in more often than what they were before? So we were able to look at the previous 6 months and the next 6 months and so we weren't significantly getting people coming in more often or anything like that. And that was just going through what the costs would be. So this was, and pretty much this is what we ended up getting funded for under CPAMs. So what the costs of the tests were, and we sort of averaged out. We thought we were taking about six or 7 minutes, and so that's where they sort of, I think they're paying pharmacists about $15. And that's just we went through and we sort of said, no, why should it be a pharmacy-led service? And I've got a thing. Sorry, my disclaimer is I'm an advocate for pharmacy. As the Vice President of the Pharmaceutical Society, I'm constantly saying pharmacists can do more, let us do more, give us more funding. And so that's my disclaimer. That's what I'm guilty of. And so now we're actually up to now. So these are things which I've just pulled off the TAS website. So they because everything's online, they can actually, it's pretty easy to actually keep monitoring it and know exactly what's happening to do with warfarin. And it's always the fear. So the initial 15 pharmacies, as early adopters, might have been really passionate about what they're doing and do everything really brilliantly. What happens when you get the next cohort of pharmacists coming on and doing it? Is there going to be a drop off in quality? And this shows that there hasn't been. It's still 74% time and therapeutic range. So now it's actually there's 167 pharmacies who've got contract, and there's now 7,243 patients. That was the figure which they must have come up with between July and December. And the tests on time has probably dropped a bit. So that's if they come in on the day that you've asked is 74%, 1 to 3 days late. So that will take it up to about 87%. So pretty much for people are coming into the pharmacy on time. I've got this thing I speak about with pharmacy with 3 A's: accessible, affordable, and accurate. So often the reason why people manage to come in is because it's quite accessible to come into the pharmacy. What we always do, we don't tend to have times for patients. They come in when it's convenient for them. So we're open from 7:30 in the morning to 5:30 at night. So as long as they're not coming in and bang on 5:30, everything works fairly well for them when it's convenient for them.
So there's no cost to the patient when they come to you?
No, there's not. It's funded under CPAMs. The problem is that there's only so many patients, there's a limit, and so depending on which DHB you're in, you can either have a great deal of CPAMs cover or you can have a very little amount of CPAMs cover. Some of the DHBs allow more, they do extra funding over and above what the national contract is. It's a funny thing about the machines, because when we were first doing it, I approached the Midland John McCaskill Smith, and I said this is what we're looking at doing, and he said, "Oh, well, that's all great. Do you want some more machines? Because I've got a cupboard full back in my office, because they were all given to the GPs by Roche, and no one wanted to do it." So I must admit at the time we were sort of like, oh, we had to go and buy our ones and that. So yeah. So that's just the demographics. The majority of patients are for AF and the ethnicity. So there's a real problem is how do you actually, is all about equity again, so whether or not we're actually targeting, maybe able to get to the right people. This is the ones, so we actually get feedback for our own particular pharmacy. So this is our time and therapeutic range now. So we've actually dropped from 76% to 70%. So we're still well over that 60% time and therapeutic range. And the question is, why have we dropped for? And we've still managed to pretty much stay with the national average on tests on time. The reason why we've dropped is because we've actually got a large Maori population now who we're doing CPAMs for. We're actually only funded for 70, but we've got a close relationship with a Maori health provider, and so we're actually doing 60 Maori patients, and these are patients who are often hard to get, and we're doing actually for no charge. So but it's also probably the reason why we've gone from 76% time and therapeutic range to 70%, because they're harder to engage with. Yeah. And so Roche have gone, of course, because they want to get it all more CPAMs out there, and so of course they go and look and they go and present to all the different DHBs. So these were just the figures for the Waikato DHB, saying no, you've got 681 patients at the moment amongst 12 pharmacies. That's 24%, and the DHB, our Waikato DHB, says, well, that's the national average. We won't move on that, so we won't find funding anywhere else. Whereas somewhere like Nelson Marlborough, they're about 60%. I think Taranaki's about 40 or 50%, and some of the Auckland DHBs, they're about 9%. So the Auckland DHBs haven't really engaged very much whatsoever. And so these slides, just, and you look at them again later when in handouts or whatever, but it just goes through and shows what would be the effect if you're looking at the bleeds or the strokes, which if pharmacy was doing more CPAMs, what we could actually prevent, and what the estimated cost savings would be for those. So that's then increasing it all up to 50% and then up to 80%. So just extrapolating out what the cost savings could be. So if you can just bear with me, I thought I'd give 2 case studies. These are real case studies from our pharmacy. And so the first one is and now if you've got any questions, please just yell out and that sort of thing, ask me anything. So the first one's a 77-year-old man who's got AF. He's on 3 milligrams of warfarin, and he comes into the pharmacy pretty much monthly on a regular basis, and we also do all his medication for him. So I grabbed it just purely, I just grabbed it purely from our computer. This is the incident form that we'd written up. So the patient presents into the pharmacy, and the problem was the INR machine couldn't read the result. It came up with an error. So what do you think the pharmacist would do when it came up with an error? So you start off with the algorithm and you ask them the questions. So has anything else changed in your life, and are you drinking more, or are you taking any other medication, and those sorts of things? So what do you think the pharmacist would do when it came up with an error? Yep. So she did another finger prick for the man just to see whether or not maybe she'd done the first one wrong, and it came up with the error again. And so what would you do next? So we're lucky in our pharmacy we've got 2 machines, so she went and got another machine, and she pricked him again and still got the same result, and pricked him a 4th time and still got the same result. So, yeah, that was one of the options. She could have checked it on herself, or the other option, she could have asked other pharmacists, have you used the machines today, if they worked all right? And the answer would have been yes, they've worked fine. So then she did the research and discovered that no, probably the reason was that the level of his INR was too high, and it was outside of the zone for the machine to actually read it. So what happened next? We then, because there's his doctor was just next door, we then organised a lab form for him to be sent off to off to Path Lab straight away, and then we rang up Path Lab to find out what the result was, and they said it was 30. And that was the reason why we couldn't get a result. So I think it goes up to about either 12 to 15 or something like that. So, but it's just way off the scale and that sort of thing. When we'd asked him, when he was in, we'd asked him, had he had any bruising, had he had any bleeding? And also the funny thing was, I've asked the pharmacist, when you pricked him, was his blood not flowing really freely? But she said no, it didn't. But yep. So we got him to quickly come back to the medical centre, and the doctor, he rang up the haematologist, and we went through those sorts of processes, and then we gave him some vitamin K. How much vitamin K did we give him? We gave him 5 milligrams, because we were always thinking about in 2 or 3 days' time how we get them actually back to his normal between 2 and 3. And then we got them organised to go up to the hospital, where they kept them overnight. So the question for you would be, why do you think his INR was so high?
Was there a dispensing error?
Who said overdose? It's an overdose of what? Yeah. Yeah.
Intentional or unintentional overdose. get mixed up, or did he want to?
Yep, so we asked him to bring in his tablets, and he brought them in, and he'd been taking 5 milligram tablets. So instead of taking 3 by 1 milligrams, he was taking 3 by 5 milligrams, and he's been doing that for about 2 weeks or so. So, yeah. Clearly labelled, but he's 77-year-old man who's confused. No, he's getting older and that sort of thing. He'd maybe run out of his brown ones. He just grabbed those ones. They were an old bottle that he had in his cupboard. Yep. So he came in, of course, on the next day, and for the next 3 days he came in, and we were able to get his INR back in range. So that was all very successful. And then the next thing, of course, we did is we organised for an MUR pharmacist. So who's an MUR pharmacist? And what do MUR pharmacists do?
Medications?
Yep. So we got the MUR pharmacist to go around and see him, so we can find out exactly what he had in his medicine cupboard, how he was coping with his medicines, going through his medicines with him, taking away all these things, had the conversations with the GP to make sure that he only ever prescribed 1 milligram tablets, which we always try to encourage so that people can't get confused. And he's all working fine now. Now the next one is a wee bit trickier, and we just have to treat this all with with a degree of sensitivity and things like that. But I think it's really quite useful to go through and things like that, especially in the light of Rachel's presentation earlier on transitions of care. So Mrs. P came to us via a rest home, where we were providing her testing. So she was in the rest home, and because we had the relation, we did all the medication in the rest home. We found it, the rest home finds it easier for us to go in and just do the testing there. But she'd only been in on respite, and then when she went back out in the community, we continued to go, and often once a month, because she's 84 years of age, and she was confined to a wheelchair. And so we've been doing that for about 2 years. We weren't actually providing the medication, so we've actually had we had a discussion with our DHB planning and funding managers around CPAMs, and we'd sort of often said, look, we need to be able to be managing all of their medications because we're taking responsibility around their CPAMs. But planning and funding said, well, no, all you're doing is you're monitoring their bloods. So you're just doing exactly the same as the laboratory. So we accepted that. We didn't actually monitor any of her medication. So Mrs. P suffered from some serious medical conditions and was confined to a wheelchair. She'd had an aortic valve replacement in 2007 and was on warfarin. On the 11th of February, she complained of pain in various places while her caregiver was calling for an ambulance. Mrs. P suffered a seizure. The caregiver commenced CPR, and the paramedics continued this upon their arrival, but Mrs. P couldn't be revived. A post-mortem examination of Mrs. P has indicated the cause of death was set out as an above, which was fibrinous obstruction of aortic valve prosthesis. So then it was just going through the process of trying to determine why that had happened. Mrs. P lived alone, and because of her medical conditions, she had a caregiver visit her house every weekday for around 1 hour. The report from the general practitioner, so this is the coroner's report. So the coroner, of course, called for reports from ourselves as a pharmacist and also from the general practitioner. So the report from the general practitioner said that Mrs. P was taking warfarin because she had an artificial aortic valve. The GP had last received INR results for Mrs. P on the October the 7th. So with INR online, when you get the results and it goes online, there's an email sent directly to the GP. So, and at the time, the results were therapeutic. The report states that since that time, Mrs. P was under the care of Waikato Hospital. The GP anticipated that the hospital was monitoring INR level. So Mrs. P then came out of the hospital, and the discharge summary from the hospital made no reference for Mrs. P actually being on warfarin. When informed that the hospital was not monitoring the INR level, the GP informs that this was being done by the pharmacy. So of course we had been doing it, but when so inquiries were made of the pharmacy and a letter was received enclosing a copy of the report from INR online. The letter notes that the final test was performed on the 7th of October, with the next test scheduled for the 28th of October. At that time, Mrs. P was in Waikato Hospital. On the 16th of January, the pharmacy noted that Mrs. P was being removed from the program as the pharmacy was unable to ascertain from her what was occurring. It appears that the program referred to was a community pharmacy anticoagulation scheme. The letter records that the pharmacy was not dispensing any warfarin tablets or supervising Mrs. P taking of her medicines. So what happened is we kept on trying to contact Mrs. P. We weren't able to actually get hold of her in any way, and so as we're only doing her blood tests, we in January time, so that was about 2-3 months after we'd actually last seen her, we disengaged with her. The evidence indicates that Mrs. P's INR level was not being monitored following her discharge from hospital. The hospital discharge summary provided by the GP indicates that she was discharged with a 30-day supply of warfarin. So that's where some of these things get confused, because at one stage they're saying that the hospital discharge didn't say that she was on warfarin, and the other one says she must have actually been given a prescription for warfarin. The GP indicates that either the hospital or the pharmacy undertook the monitoring of the INR level post-discharge. The Chief Medical Officer of Health for Waikato informs that the responsibility for the prescribing and monitoring of warfarin transferred to the GP upon the discharge from the hospital in accordance with usual practice. So in other words, the patient went out with the discharge notes, and where did the responsibility go and things like that. The pharmacy informs that it was simply providing a laboratory service to Mrs. P, which involved conducting INR testing. It did not dispense warfarin to Mrs. P, and therefore did not assume responsibility for monitoring the INR level. It also becomes that tricky thing of when maybe I'm not sure if it's who took Mrs. P out of hospital, but I think they actually stopped at probably the after-hours pharmacy and picked up her medications from there. So the problem is that again you've probably got the prescription being dispensed from one pharmacy or from numerous pharmacies. So we made repeated attempts to discuss with Mrs. P her involvement in the anticoagulation program, but we were unable to successfully engage with her. The pharmacy also informs that it did not receive any information from the hospital. So unfortunately we didn't in 2014 get any access to discharge notes or anything like that. So when the patient was discharged, even though we'd been doing CPAMs for 2 years, no one actually told us that she was actually going back out into the community. The GP report shows that Mrs. P last consulted a doctor at the surgery in September 2014 prior to her hospital admission. She did not seek a prescription for warfarin when her last dosage had been consumed in November. So I think they just decided if she'd had 30 days that she'd probably used up all of her 30 days. But she was 84 years of age, so there was actually no way of knowing, I felt, of whether or not she was actually taking her medication or not. She had a caregiver going in, but sometimes the caregivers do medication management, but I don't think in this instance they're actually doing medication management. The report does not provide any information on whether any attempts were made by the practice to contact Ms. Patterson in the relationship to the monitoring her INR levels or providing a repeat prescription for warfarin following her discharge from hospital. So this is all a very sad case. So the comments are, Mrs. P fell through the cracks with regard to the monitoring of her INR level and her prescription for warfarin from November 2014. So the question was, of course, was she actually taking any warfarin? We know that, of course, that she wasn't actually being monitored for a warfarin. And so that I probably think this is actually the unfair part, but where did the responsibility lie, or who I'm not sure if it's at fault, but where did the coroner say the responsibility lay?
How capable was the patient?
Well,
84, then it would be very good.
yeah, I trust that Mrs. P, General Practitioner, will give consideration to a medical practice process for monitoring prescriptions to patients for warfarin to ensure that such processes are sufficiently robust to prevent a reoccurrence of the situation, which all seems completely unfair to me, because I think that there was a number of hiccups throughout the whole system and things like that.